Hello, welcome to this March session of the Derby Health and Wellbeing Board. It's nice to see so many people here, and particularly yourself, Mike. Thank you very much for coming and joining us. We do appreciate it. Thank you. Do we have any apologies, Lindsay?
Yes, we do. We've got Emma Aldred, but Mike Seidman's covering. Lucy Allen, but Heather Longbottom is covering for Lucy and Jim. Denise Baker, but Andy McBarl is covering. Kathy McLean, Jane Needham, Nav Sahota, Mark Powell, and that's it.
Thank you, Lindsay. Yeah, I think there's a bit of noise on your... never mind, thank you. So just to remind anybody who doesn't attend regularly, if you'd like to speak, there's a microphone in front of you. You just need to press the button and a red light will come on and you can speak. But the tricky thing is to remember that after you finish speaking, you need to turn it off, or else then we can't hear everybody else as clearly. That's something that most of us forget, actually, at some point. Thank you for that. There are no late items, but unfortunately, we won't be able to take the item number 8 today, the oral health strategy, for various reasons. So we deferred that probably to the next meeting. Is that right, Alison? Yes, thank you. Do we have any declarations of interest? No. And is everybody happy to accept the minutes of the last meeting as an accurate record of the meeting, those people who were there? Yes. Okay, thank you very much. So item 5, it's our first item, which is the Health and Wellbeing Board plan, and or the action log, in fact, isn't it, Alison? Yeah. And I think everything in there is either complete or in progress, so I don't have any problems with that. Is everybody else happy with where we're at the moment with our action log? We do try and follow things through, to try and monitor it. No comments on that, that's fine. Thank you very much. So now we'll move on to the Children and Young People Plan, which Sue-Ann Lim, Derby's Director of Children's Services, is going to present. You're not the Director of Children's Services, is going to... That's you, Andy. So, well, you're the Strategic Director of Children's Services. Anyway, Sue-Ann, please feel free to introduce yourself and to give us your formal title, please. Thank you.
Thank you, Chair. I'm Sue-Ann Lim. I'm the Director of Early Help and Children's Social Care. Thank you. And the report that you've got in front of you is a retrospective overview of the Children and Young People's Plan 2022 to 2025. If board members will recall, is at some point in 2024, the Children and Young People Learners Board was subsumed into this board, but we never closed the loop in terms of finalising what the achievements and outcomes were from this plan. So I'm wanting to take board members through 10 points of that plan, and it's appended, and it's the first column. So it's about more people feeling safe, and our children and young people and their families feel safe and are safe. So there are 10 objectives, as I've mentioned. If we could have the next slide, Lindsay, please. And the objective of the plan was to ensure safety and welfare for children in Derby, adhering to the plan's goal. Our children and young people and their families feel safe and are safe. And as we will understand, safeguarding is a partnership shared responsibility, not just amongst statutory partners, but across multi-agency sector as well. So within that context, those achievements across the whole partnership. So next slide, please. So in terms of the first action, which is around missing episodes, so really delighted to report that there's been a year-on-year decline in the number of children in care missing episodes. which has been significant. So in the report, you will see at section 4.1 in the table that in 2022 there were a total of 1,631 episodes, and by the time that we had been through the duration of this plan, that had significantly reduced. It's clearly still very high, and we're still worried about it, but it has significantly reduced, and I think that shows as testimony to the partnership working and the protocols and everything else that has been put in place, and we'd reduce the total.
Sorry to interrupt,
yes.
but I have a question on that specific. So do you mind just a point of information on that table in 4.1? Do you mind if I ask it you now?
Yes.
Thank you. So I'm a bit unclear, and because this is obviously a critical point, isn't it, about children missing? So if we take 24 to 25, you seem to have, it's obviously, without going into any huge detail, it is fantastic the numbers going missing or reducing. But is it that are those two sets of numbers in column 3 and 4 the wrong way round? Total missing episodes care experience of children 328, total number of young people 55. Is that the wrong way round?
No, it's not, Chair. So there will be a proportion of those 55 children who will have gone missing multiple times. So the 328, so on average, there's about six times each of those 55 children have gone missing on average.
I see
yes.
what you mean, the number of in total.
Yes.
So the number of, forgive me for being pedantic, but if we said it's the total number of care experienced children, the total number. Or, I mean, the thing, so forgive me on this, but it seemed to me important to try and understand the point. Because when we say young people, do we mean, it implies, seems to me to mean out of all young people in the city. Are we talking about all, I mean, is any of this referring to all young people? Is all referring to children in care?
That's correct, Chair.
I see. So there's the number of, just for real pedantry here, so it's the number of episodes, but it concerns 55 children or young people in care.
Yeah, sorry, apologies. The first column is total missing episodes. The second column and the final column is around children in care.
Okay, so the first column does refer to all young children and young people in the whole city. Okay, sorry about that, Suan. It seemed really important to me to understand it for the whole point. But thank you.
No, apologies if there's any confusion there, Chair. So moving on then to some missing episodes. Again, we have had significant success over the 3 years plan. Second element was around educate and support parents and carers so that they can make safe choices when caring for the baby. So we've had quite a lot of work across the partnership and within children's social care around this. We have developed some specialist support for parents. We've also, over the years, developed what's called a Keeping Babies Safe strategy, which originated from the risks that were evident during COVID for young parents, first-time parents and mothers going home with their babies alone. So that again has proved to be really supportive. And of course, we've had the launch and rollout of our family hubs over the last 3 years, which again has contributed to significant amount of support for families and children, and is ever evolving, and will continue for another 3 years under the Best Start for family hubs and school preparation. So there has been over a 50,000 footfall to our family hubs over the that's just in the last year, which is exceptional. So we're doing quite a lot in that space, along with partners. In terms of exploitation and prevention, we again have had a number of successes in this area. There's quite a mature partnership arrangement around child sexual exploitation. And again, the table at 4.3 shows the level of reduction in that area, and for assurances, this also goes to a number of different boards, and it is because of the level of interventions and I suppose the grip that partners have, that we are assured that that reduction is a safe reduction. People are more aware of the risks of exploitation and managing that risk without it escalating. So all of the interventions on page 4 are kind of a partnership approach to making sure that we manage child sexual exploitation. So you can see that we have reduced those numbers of children, but also the number of referrals that are needed to keep children safe, as it were. Thank you. So moving on to page 5, ensuring consistent early referrals to social care and early help where the risk of domestic abuse is identified. We know that we've got a significant amount of referrals that come into our front door in terms of our multi-agency safeguarding hub. So in terms of domestic abuse, we know that 50% of those 2,500 referrals are domestic abuse. So there are consistent, and it's probably too high, but there are definitely consistent referrals coming in around domestic abuse. And part of our Families First initiative, we are looking to manage that in a much more equitable way and do domestic abuse triage. In running in parallel, the Safeguarding Partnership also have domestic abuse as one of their key priorities as well. So we haven't, I would say that's probably an area where we're still working on. It's still a key risk for the city in terms of those for the children. Moving on then to increased numbers of families staying together by using a strength-based approach. I've put in there our looked after statistics, and you'll see then at 4.5 that we have got a downward trajectory, and that's a deliberate downward trajectory of children that are being looked after by the local authority. Absolutely peaked during COVID, but again, we are trying to safely, where it's safe to do so, ensure that children are placed within their family or within the wider family environment. We have got a higher proportion still of children who are looked after by the local authority in terms of our comparator, or per 10,000. So we should have, if we were working towards about 450 to be about right for this size of authority. But we're getting there, and we're going in the right direction. We've got lots of interventions and services that are helping families stay together in a strength-based way, so that there is sustainability there. So moving on to then serious youth violence reduction. So again, there's a couple of tables on page 6, which probably contrary to perceptions really around youth crime, is showing a vast reduced picture for young people within the city. The Youth Offending Service, working alongside the Community Safety Partnership, working alongside police and partners in the city, have been really effective in managing this area of risk. And you'll see that in terms of serious youth violence, that's reduced down over the course of the period of the plan from 182 episodes to 248, but within this year was 79, the equivalent of 86 by the end of the year, and that's a 42% reduction that we've seen in charged violent crimes. And again, the perception I appreciate is different, but the actuality is as it is here. And the same with knife crime as well. You'll see that there's a considerable reduction. We have had a huge focus within the city on knife crime and working alongside schools and preventative services to address this issue. And again, we can see that in this year, 26 incidents, or 26 young people with knife crime incidents, which would be extrapolated to 28 by the end of this financial year, which again indicates a 32% reduction. So again, that is excellent news. Moving on then to reducing risks of online incidents involving children and young people. This is a strategic responsibility for the Board of Online Harms, and that sits within the Community Safety Partnership. Significant work has been done within that board and across in the Safeguarding Partnership around this area. There's a whole range of different resources that are available to schools in the hopes that the awareness is being raised and that the priority in this area for the Safeguarding Partnership continues with a really ambitious set of actions that they're still taking forward, and we recognise that this area is not one that can be done and closed. It's ongoing and remains a key priority and a key risk for children. Reducing the number of children and young people missing education. I've put a quote in there around how our systems work across between social care and education, and our Ofsted inspection last year commented that the systems that we've got, the majority of children missing education are located quickly because there's cooperation between the local authority, other local authorities and external agencies. And when children are placed on part-time timetables, the same teams are proactive in making sure that these are short-term and that support is in place. Great support from the police in identifying those not in school or electively home educated. And over the course of the year, those numbers had reduced. I just need to caveat that by saying at the end of the year, they had reduced. I think electively home education, as I've learned recently, has just increased in the course of this year. So again, still remains a priority. Moving on to the COVID-19 and then mitigation of impact. So we know that we've been key partners, and there's been a huge multi-agency approach to creating a city poverty strategy. I'm probably not the best person to talk on that because I know there's more people in the room who are experts, but that's needless to say that we are active participants in that. That is a live strategy that is ongoing, and again, really excited to be part of the delivery of that with our families first and making sure that anything that we do contributes to the outcomes for the city with that strategy. But again, that over the course of that plan, that has developed and has made significant progress for partners. And I think finally we've got to provide early help and targeted support to reduce the demand for statutory services. So again, we're looking at all of those services that prevent the escalation. And again, we've got you know, a number of different practices there that you know contribute to preventing that escalation. I think everybody within the partnership does their best to prevent cases coming into statutory services. But I think there's probably more that we can do in that area. And again, Families First will be designed and focused on making sure that that's taken forward. So, Chair, overall, I would say there's lots to celebrate from the plan, lots of progress that's been made, still things to do, because I think there always is with children's safeguarding, but I'd ask the board to note the report, and I'm happy to take any questions. Thank you.
Thank you, Sue-Ann. It's a very succinct and comprehensive at the same time report, and overall the plan seems very, and the outcomes seem very encouraging. As you say, there are obviously a few areas that require more work, and obviously it's not for you to incorporate this in the plan, but it's something that we might want to reflect on as citizens of this city and some others around the area. Is, you know, what our perceptions are and our understandings is of the life of young children and young people, when most things that are reported seem to be very negative, or many things that are reported seem to be focusing on problems. I mean, that's true of general public discourse generally these days. And whilst there are many problems, there are certainly some encouraging trends in this report. So thank you very much for bringing it here. It's an extremely important report. Do we have any questions or comments for Sue-Ann? I have Councillor Ashby first of all. Thank you.
Thank you. Thank you very much for the report, and it's great to see the improvements that have been happening year on year. I think what would be helpful for us to get a better grasp of the scale of the improvement, particularly for children, looked after children, is if we, you know, for example, the stats for the missing episodes and the children who are at risk of exploitation. If we had a percentage, you know, we have the total numbers of referrals for exploitation and the number of care experienced children, but we have no concept of how those numbers relate to the percentage of children of that age in general in the city by comparison to the percentage of children cared for in the city. So I think in future reports it would be really good to have that extra level of information so we can understand better.
Thank you for that question. I think this is probably a one-off report because this plan is now obsolete. However, I think as the chair of the Corporate Parenting Committee, we get much more of a deep dive into those statistics for missing children. That comes to that board. So I can definitely make sure that does happen. But I feel sure for the exploitation and for missing that there's a much deeper dive into the percentage and everything else for those. But that goes to the corporate parenting. Thank you.
Councillor Kerr.
Thank you very much, and I really appreciate I want to highlight some of the things that have been good news stories on here, because I think quite a lot of them relate to more personal service. So in terms of things like the early help, when people are being able to be not just part of the mainstream, but they are being listened to. And I think for so many occasions, it's being listened to. And as a young person who might have run away from home, it's being listened to that can make the difference between you feeling that there's a point in running away and actually you don't need to run away because someone's going to listen to you anyway. That one of the groups, I want to link in also to the COVID-19 link here, and we're getting the statistics nationally of the number of young people who are not in work. And okay, that's sort of off the top end of the range of young people we're talking about in this context, but I think that same message about treating those people as individuals is going to be so vital to be able to move them forward. And I don't know whether it's something that we have any influence over, because particularly if somebody has missed out on doing their GCSEs and therefore they've not got that as an item on their CV, and therefore they can't jump through the first hoops of getting a job because they've not got the qualifications, because they couldn't cope with working at home, and you know, everything is falling around. And they're now in their early 20s and still being held back. They need to be treated as an individual and assessing their capacity, not the things they've been able to do in the past. So I don't know how, Chair, we feed that sort of thinking that I think we're achieving here with children and young people into that slightly older age group when it's not primarily the council that's responsible. But I just wonder if there is partners here who can see that there's some synergy as to what they're doing.
Thank you, Councillor Kerr. Sue-Ann?
So I think we have got some strategies, Councillor Kerr, in terms of the Derby Promise, and also we're reinvigorating our NEAT strategies. That's not in education, employment and training, which that goes up to 25 and crosses that cliff edge of 18. So I think we have got mechanisms in place to do that. And also, if a child is a care leaver, they have an individual personal advisor who, again, if I actually, listening is really important, and who will be there, almost their chaperone, their ambassador, navigator through some of those tricky areas, including training or employment. So we do have a number of different mechanisms moving into adulthood, and maybe there's something in adult social care as well, I don't know. Thank you.
Thank you. And I know you want to come in, Paul. Before I do, did anybody else want to respond to Councillor Kerr's point as she put it out to the room? No? But it's a very important issue that you raised, Councillor Kerr. I know the government is mindful of it, and I think I'm trying to pursue some strategies to deal with it, but it is something we need to keep an eye on, I think. Thank you. Paul Bookhouse.
Thanks, Anne, for that. I know me, Sharon and yourself are going to be meeting around the child strand of the poverty strategy, but something that triggered there for me was about how we look going forward, the impact of poverty has on all of these areas, and actually if what we do, if we tackle poverty as the underlying benchmark, how much that might help in terms of improving in some of these areas would be good for us to be part of that discussion, to see what that negative input is, but also what the positive input can be if we actually address some of that.
Thanks, Paul. I mean, poverty is really clearly fixed and centre in my mind in terms of any development of practice. So certainly the families first drive that we've got is, for me, it's all about trying to strengthen, unite and to complement what's already in that universal space at that family help at the lowest level. And I think, we recognise that in order to support families and children at that level, you have to address poverty, you have to address cost of living, you have to address neglect, and it's those wicked issues that we have got in the city, and it never has been a better time. So for children's social care, we've got the families first. The communities in place have got their community hubs. We're working really closely with our alliance friends. So we've created a family alliance to support in that space, and our education colleagues as well are really looking in that space. So I think there's a real momentum, and then across police and health as well. There's a real momentum now around that early help, prevention, meeting need where it's actually emanating from, before it escalates into something more. So no, it's really exciting times at the moment, Paul. Thank you.
Thank you. And just before I bring Amjad in, I mean, remember, Paul, when we had the Child Poverty Action Group come to address us last year, and they said that the biggest single thing that would help child poverty is lifting the two-child benefit cap, which has happened. So that's one positive thing, as far as I'm concerned, that we have seen happen. But obviously that's only ever one measure. But they did say it was the single most important thing in the current time, so that you could look at that positively, I think. Amjad, thank you.
Thank you. Yes, Swan, it's really encouraging to see the progress that's highlighted in the report. I think from a community perspective, and just building on your comment relating to the Families Alliance, there's a real opportunities for us to strengthen that relationship with trusted community organisations, because we know that there's many safeguarding concerns that would probably be brought to the attention within communities, especially around hidden harm. So embedding that in would definitely strengthen and help with sort of early identification and that prevention work. So yeah, it's exciting times.
Do you want to respond to that at all, Sue-Ann?
I mean, absolutely. I think, you know, I'm really excited about our Family Alliance. I think having the voice of both the community but also parents and is absolutely key for us to drive forward. So we need to see that as our critical safeguarding partners. I think in terms of the relational gaps that you're talking about, I would want to be talking in improving that social contract. Our social care want to improve that with parents, and if it needs improving with the community, then we need to do that as well. And I know if Sharon was here, Sharon would be talking about improving the social contract between parents and schools as well, to improve education attainment and attendance of children in schools. And I think, you know, all of it in the round has to be seen as part of that journey. So, I mean, I very much see Families First having a huge part in that early space between years 1 to 5, best start family hubs, etc. And I know that Amjad, you're involved in that work. But yes, I think it's across the board, and I think we're knitting that more together. But there's lots of work to do. But yeah, you're right. It's exciting times. Thank you.
Thank you. And I imagine we'll receive an update on the Families First work in due course, will we? I think it's on the plan, isn't it? Yeah. Okay, that's lovely. So do we have any further comments or questions for Sue-Ann? No? Well, in that case, thank you very much, Sue-Ann. It was a really interesting and positive report. Thank you very much for all the work you do in that area. So we're going to move on now to the report on... actually, Sue-Ann, your recommendation was mainly just to note and support the report, wasn't it? Which I think we've done. Thank you. So now moving on to a kind of interim report in some ways, I believe, on infant mortality. Perhaps Robin can explain why it's a bit interim. But it's so important that I did ask for it to come to the board. And it's so concerning for Derby that I didn't want to delay us discussing it again, as actually it's an area that isn't discussed that much anyway. So what we can do here at the Health and Wellbeing Board is actually make sure that we do discuss things that are important that may not be being discussed elsewhere. So, and I understand that Robin is going to present it today because Kerry Hodges has been called away urgently. So over to you, Robin. Thank you.
Thank you. And forgive my voice today, I'm a little bit croaky, but so next slide, please, Linz. Thank you. So you may remember we had a presentation, it was January last year, 2025, and we were looking at infant mortality and the work that had been done. And so we just got a little recap around that work. So infant mortality, when we say infant mortality, what we're talking about is deaths of babies within the first year of life. And I'm sure you can imagine that most of those deaths are happening in the first month of life, when babies are most vulnerable. And many of these deaths can be prevented either through healthcare or through other activities, reducing risk factors in other ways. And there's been a lot of improvement in this over the last 40 years, but both locally and nationally, that progress has really slowed over the last 10 or so years. And we now have worse figures in the country compared to our European neighbours. And also, Derby was highlighted as having the second worst figures for the East Midlands as well. So, to go on to the next slide. Thanks, Linz. And it's important to think as well that the causes of child deaths are not only the causes of those child deaths, they're also the causes of ill health in many more children. So anything that we can do to tackle and reduce the risk of these child deaths can also improve the health of children much more generally. And this is both in physical and mental health as well. And importantly, thinking about the health and well-being of our families too. So obviously children who are born prematurely have a much higher risk of death, and so some of the actions that we can take can also reduce the risk of premature birth as well, and so in doing that, reduce some of the risk of those health issues associated with premature birth. Next slide, thanks Liz. So there was a deep dive into infant mortality in Derby, and just a reminder, the key issues that came up through that piece of research work was risk factors associated with children, so as I mentioned, low birth weight and prematurity, but also infant feeding and sleeping arrangements. For mothers, risk factors associated with smoking during pregnancy, obesity, mother's age and substance misuse, and environmental risk factors too, so thinking about mental health in the parent, domestic abuse, conditions within housing and air quality. So there was an action plan that was drawn up from this, and there's been a group meeting to progress the action plan. So this is an interim report into the progress of that group and some of the areas of work that they have carried out to date. So it developed a healthy pregnancy checklist, and this is for all professionals working with families, and is particularly to highlight some of those risk factors and to support professionals to signpost women and families towards support within the community that can help to reduce those risk factors. And a specific risk assessment developed for midwifery to focus on social factors as well as the clinical factors during pregnancy. And then also postnatal checks in primary care, so thinking about that 6 to 8 week check when women will go for a check, and their babies will also receive a developmental check, to have a checklist to go through to make sure that some of those factors are considered in that contact, and there's a conversation about those. And the next slide, thank you. And through all of this, community involvement and engagement, so working with our colleagues in community action, thinking about how we can ask the right questions to identify these risks, and that work is being developed and continued to embed, and particularly to embed that co-production in some of the work going forward. And a couple of other things to mention. I think that might be the last slide, is it? There's also been some work about to simplify and to improve communication and referral mechanisms. That's always an issue, isn't it, with many services, and also mapping what's available within the community, so that's much more, professionals are much more able to see what is there. And just to mention, there's a child death overview panel which reviews child deaths, that's all children under the age of 18 for Derby and Derbyshire, and they produce an annual report, and that report will include consideration of these deaths under 12 months as well. So that annual report is due to be published shortly, in the next couple of months, so we will be planning to bring that here. So I imagine one of the questions is, have these actions made any difference? The difficulty with our data is that the latest data that's published is up to 2024. But when we look at the Child Death Overview panel review, that's the latest financial year's data, so that will give us a lot more information that's more up to date as well for board members to see. Thank you.
Right, thank you, Robin. It's quite a serious and perturbing issue, so we do need to keep focusing that. So we will welcome the report that you mentioned coming back here, some discussion of that. Thank you. Councillor Wright.
Thank you for the report, albeit on a very, very sad and disturbing topic. Could you say a little bit more why Derby, the death mortality rate is so high for Derby? Perhaps you can, although it is an interim report, but I would welcome any further commentary there. Also, are there ethnicity factors? And finally, in terms of socio-economic factors, are they subsumed within environmental risk factors, please? Thank you.
Why is it higher in Derby? Well, we do tend to see that infant mortality is really strongly related to deprivation, and so we see that areas of greater deprivation tend to have higher levels of infant mortality. And the deep dive that was done picks out on some of those areas that are the underlying risk factors and causes, and we know that many of those aspects are also related to deprivation as well. So low birth weight, prematurity, smoking in pregnancy, maternal obesity, you know, many of those are, there's an interplay between all of those and deprivation as well. From an ethnicity perspective, the numbers, I believe, in Derby are fortunately too small to be able to take any conclusions from that. But I do hope that that's recorded in the child death report that will come, so hopefully that should be in there to give us a better indication. But we're generally talking about 15 to 20 deaths a year when we're looking at infant mortality. So it is a little bit difficult to take any conclusions from that, but we also know that anything that's related to material deprivation can also be strongly related to ethnicity as well, can't it? So it's a complicated interplay of those factors. Apologies, I've forgotten the next.
In terms of socio-economic, I asked whether socio-economic factors are subsumed in your environmental risks.
Yes, they are. Yes, so it's relating to
Social class, basically.
housing
So
quality.
working class,
Yeah.
death are likely to be in particular social class groups.
Yes, so particularly related to deprivation, yes.
Thank you, Councillor Kerr.
Thank you. You said that we're the second worst in the East Midlands, and I was wondering how we compared with our comparator authorities and whether we're at the bottom there as well, or near the bottom there. And whether we can look at those comparator authorities and see which are doing particularly well and what messages there are that we can learn from similar authorities which are doing better than us.
So when we look at the data for the other authorities, we're more middle of the road, I would say, which is not a place to want to be, but we don't really stand out. But at the moment, there is a stream of work that's being run across the whole of the Midlands, so the East and the West Midlands, by the Office of Health Improvement and Disparities, who are looking at a programme of work around infant mortality. So there's an ability through that work to look particularly at what other areas are doing and what's being successful in those areas. Does that answer your question, Councillor? Yeah.
Thank you. And I just have a point, Robin, following on from the previous points. And in a way, I suspect you won't be able to answer it, but I'm just wondering if it's part of the analysis and considerations, because I suppose, there's two, I very much support Councillor Wright's questions around socio-economic factors and ethnicity in this, but also I can also recognise that when the absolute numbers are relatively low, it's difficult to necessarily draw any strong conclusions. I mean, it's worth saying that all of these deaths are tragic and there are too many, but the absolute figures, fortunately, are still quite low, which doesn't mean it isn't a cause for concern. So, I mean, for me, it's almost that my question or my concern is partly generated by the fact that the numbers are, fortunately, in many ways, in an absolute sense, low, because we know that over recent, I mean, if there's a correlation, there's probably, I don't know if there's a causal, but there's certainly a correlation in time between the declining maternity services in this country, which is becoming a national scandal, and what is a national scandal, it's not becoming one, it's just that we're getting more and more services are being looked at, and this rise in infant mortality. And whilst I totally understand the point you made about the wider determinants of health being critical factors, as we know, none of those particular determinants of health stop as soon as somebody walks into a maternity suite. Some of them are very alive in that environment. But also, you know, given that the deaths are low, so if you're looking at this percentage-wise, if we had 2 preventable deaths a year in a hospital, in our hospital, in the Royal Derby Hospital maternity suite, that would give us, you know, over a 10% increase in infant mortality. So, and I know you deliberately haven't given us figures and percentages, but do you see my point? And I'm wondering if any connections are being made, if only to rule it out, to reassure the health service that that could be ruled out. But I think it will be of concern to the public. Thank you.
So the regional work that's been happening has been looking both at public health actions and also at maternity actions as well. So it's been covering all of that pathway because it involves NHS England as well within that work. And the hospitals conduct their own investigations into stillbirths as well as then contributing towards the infant mortality. So all of those child deaths that then go through to the panel for consideration will take into account the wider determinants of health and any health care that those children have received as well. So I think when we receive the Child Death Overview Panel report, I think that might be a little bit clearer. We can have a further look into that.
Oh, that's really helpful, thank you. Yeah, I'll look forward to seeing that then. Thank you. Any other comments or questions for Robin? Is it Andy? It is Andy. Andy, thank you. I can only just see your name thing, Andy, so thank you.
Thank you very much, Robin, for that work. You indicated that some of the causes or risks of infant mortality relate to the issues that are associated with deprivation, and which I was quite pleased when I heard Paul mentioning that his work is quite relevant to the plan, to the children and young people's plan. I think his work is also just as relevant to the work that you are doing. I just foresee a situation where the indicators of poverty are numerically measured and are compared to if there was an improvement, numerically improvement in indicators of poverty, how that relates then to the improvement, for example, in infant mortality, how the improvement is, as the chair mentioned, we cannot establish the association, cause and effect, but we could make a story around the correlation that if you are numerically improving the indicators of poverty, there is a numerically improvement in infant mortality.
Did you want to come back on that, Robin, or?
No, I think I'd agree, yes. It would be really helpful to have that, wouldn't it? Thank you.
Thank you. Thank you for that. Councillor Ashby.
Thank you, Robin, for this interim report. I remember the long discussion around the report last year, so it would be good to get more information with the full report in due course. I've probably said this before, so apologies. Obviously, there's a lot of great work going on and the good work going on in the healthy pregnancy work to help reduce infant mortality. One of my concerns is the pre-pregnancy period as well, not just, because by the time the woman's pregnant, a lot of the stuff is already going on, the smoking, the obesity, and sadly, too many people who have not been taking folic acid pre-getting pregnant. So is there any emphasis within this plan for that health education in schools as well as in the wider community of getting to the point of being pregnant healthy?
You'll have to forgive me because I've not been involved in the detail, but I do understand that there has been some work around healthy pregnancy, and there's particularly that advice around if you are overweight or obese, taking that additional dose of folic acid as well, which I think is not necessarily well known, is it? I think the challenge that we have is many pregnancies are not planned, but there are some planned pregnancies that we could make inroads into, and for other pregnancies it's much more about our general work that we do, isn't it, around weight management, smoking cessation, and our substance misuse services. All of those services contribute towards that.
Okay, thank you. Do we have any further comment? Oh, sorry, Councillor Wright. Yeah.
Just a quick one, Chair. The point that you made earlier about the state of our maternal care, I just wondered, are we doing any work in our locality with respect to the state of maternal care, given that there are currently ongoing inquiries that are within the region and further afield? Is this area topic part of the remit or planned work of this committee? Just asking.
Again, it doesn't come under the health and... Oh, did you want to come in?
Yes, please. Thank you, Chair. There is some work in terms of communities, certainly. So there have been quite a lot of workshops around inequality of access of services, how we can redesign services and make services more accessible, as well as a working group that's been set up to look at that. So, yeah, it is part of the programme.
Thank you, Kim. I mean, we don't have any particular impact as a Health and Wellbeing Board to any maternity services review, do we? No. I don't think so. No, we haven't. Would that be appropriate? Claire. So, Claire, would you like to introduce yourself, Claire?
Yes, will do. Thank you, Chair. So, Claire Raybold, I'm the Executive Director for Strategy and Citizen Experience at the newly formed cluster of ICBs, so Derby, Derbyshire, Lincolnshire and Nottinghamshire. So just to say, I agree, it isn't part of the remit of this board. However, just to give assurance, there is a lot of work going on in that space, as you can imagine, both locally and nationally at the moment, and through our LMNSs, and linked to all of the things we've talked about prevention opportunities as well. So, so happy to, perhaps do an update at some time, but I don't think it's a responsibility of this board. But if anybody wanted to contact me outside, happy to have that conversation.
Thank you, Claire. I mean, at some point it might be useful, perhaps when we have the subsequent report subsequent to this one, if there is a point, if those investigations have reached a certainly useful point, it might be useful to kind of assimilate them. I have talked to Alison, just as a quick aside right now, I've talked to Alison, we discussed this, but we haven't progressed it, have we? The idea of, instead of having one partner develop a report, we do it as topic-based. And we ask people, all the partners, to actually submit something to say how they're working on that area. So that's not trying to, we definitely don't want to assimilate any more areas of responsibility, Claire, or tread on anybody's toes, but it is a way of trying to get everybody to engage in what are, in terms of the strategy, we have an agreed health and wellbeing strategy, and everybody's responsibility. So in a way, it's a way of giving people the opportunity to show how they own the strategy, as well as just the person who's leading in that area. So that's something that I'm just mentioning now, because that would be a good example that without you're not going to, you're not responsible for reporting here on those reports on maternity services, but at the same time, for the public of Derby, it's very interesting, and it would sit well alongside Robin's potential report. So, and that's something we're going to think about, Alison, isn't it? And we can think about as a board, but that's an aside. Okay, well, thanks very much for that. Really important issue, and we're going to look at that a bit more. So thanks for filling in there, Robin. So we do not have, well, we do have the oral health report in our document pack, but we're not going to discuss that today because it hasn't been possible to do so, or isn't possible to do so. So we're going to move straight on to Alan Reid, who is going to give us on a report which has got a really long title, actually, Alan.
It does. It's a really long report, actually. The actual thing, even though I've not included
It's
it
like
here.
a Turner painting. They always had ridiculously long titles.
It is.
And the title is Infants, Children and Young People, 0 to 25, Mental Health and Emotional Wellbeing, Needs Assessment, Summary, Key Findings, Revised Recommendations and Action Plan. So
Got it.
you.
Thank you.
Over to you, Alan.
Thank you very much, Chair, and thank you, members, for the opportunity to present this Derby and Derbyshire Infants and Children's Young People's Mental Health and Emotional Wellbeing Needs Assessment and the proposed next steps. There isn't a presentation. I'm just going to do a verbal update in the pack that you've got a briefing paper and proposed actions, recommendations, and I'll just talk about that. I'm going to cover why the needs assessment was commissioned and what the wider context for it, where it sits, how we structured the work and who we engaged with. The principal findings with a focus on Derby City. Obviously it was done in collaboration initially with the ICB, so it was a city and county footprint and worked closely with county colleagues, but I'll give some headlines for Derby City. And finally, just thinking about the practical and action plan. We'll try to keep it as non-prescriptive with partners as possible and a proposed governance approach that we suggest partners may wish to consider, particularly thinking about the clustering arrangements of the ICB as a key partner in that. So let's start with why we carried out this work. We started this work, really it stems from a scrutiny item from September 2023 that was followed up by some local BBC media interest in child mental health. And from that, I think we just felt that there was a sense of partners across health, education, local government and the voluntary sector needed a single shared practical evidence base to inform a joint action around sort of 0 to 25 age group, children, young people, young adults. And there are several drivers for that, following on from that scrutiny paper back in the end of 2023. I think there was recognition across the system about the ongoing impacts of COVID-19. The pandemic, of course, as you know, interrupted schooling, reduced in-person social interaction and disrupted routines. And we all recognised, I think, particularly people in the education centre and out with that had consequences for children and young people's emotional well-being. Stakeholders in schools here in Derby City reported increases in childhood anxiety, reduced resilience following periods of lockdown and school absence, and that pattern was really one of the motivations for looking comprehensively across the life stage to better understand where supportive action can make the most difference. Secondly, I think we're also mindful, partners were mindful about the changing social environment that children and young people are exposed to now, the role of social media and online world shaping young people's self-image, social pressures. We actually, as part of this work, engaged the youth and deputy youth mayor to do a survey of their peers, and they told us directly that online pressures and comparisons are a real part of lived experience and influences well-being. And thirdly, national trends and local service pressures suggested that it was timely now to review how prevention, early help and specialist services are aligned in the system so partners can plan together rather than working in the usual separate silos, as seems to be the way. And that task was not conceived as a critique of existing services, but mainly instead aimed to identify shared priorities and practical opportunities. So in terms of how we structured this work, we structured it around 4 life stages: early years 0 to 4, primary school years 5 to 11, secondary school years 12 to 17, and then adolescents and young adults 18 to 25. And we did that because we felt the needs and service interfaces and effective interventions kind of differ across some of these key life stages, although there's a lot of commonality around it as well. And that life stage approach helped to make recommendations actionable at a lower local level and to align services. What we probably didn't think about too much was that just how a big topic this is. So we've ended up with 4 very big, unwieldy chapters that probably no one would want to particularly look through. So there's been some thought about how we present that online. The assessment itself can combine a quantitative review of public health and education data, policy, literature synthesis, a programme of stakeholder engagement as well. We produced a set of cross-cutting or meta themes: prevention, early help, workforce development, transitions in the community, equity and inclusion and governance, and the use of data and lived experience to inform commissioning. And those meta themes are woven through the whole action plan that you've got there. Engagement, as I said, was central to that. At the end of September last year, we convened a system stakeholder workshop, and that was well attended by commissioners across the system, NHS providers, education leaders, family hubs, and voluntary sector colleagues in that space. Workshop was an important reality check on the work, gave us some really helpful feedback and helped to really ground the action plan in the operational realities of how things work. Surfacing some practical concerns about how best to achieve to sequence the activity of the action plan. As I said, we also supported the Deputy Youth Mayor, the Derby Youth Mayor and our Deputy to survey their peers and bring young people's views directly into the assessment. So around 70 young people contributed to the Youth Mayor survey, which gave us really quite vivid insights into what matters most. Which was timely, local, non-judgmental support, clearer access routes and concerns about exam pressures and social media, as we mentioned before. And those voices have been really central in framing of the plan and something can we build on going forward. So just going on to some of the key findings at the system level and some Derby City detail. Broadly, the assessment highlighted two connected patterns. First of all, the early years is a critical prevention window period for mental health and emotional well-being. Parent-infant relationships and perinatal well-being have lasting influences on children's emotional development, which probably is not a surprise. But that really came through in the evidence review, which I think is a real strength of the work. So the second aspect that we found in a broad sense is that needs rise with age and become more complex in adolescence. Anxiety, self-harm, eating disorders are reported more in secondary age group children, and those trends mirror national patterns. But the assessment gave us a local lens on where to focus some resource. So just a few Derby-specific points relating to those individual age stage chapters, life course chapters. For early years, what we surfaced was that Derby City benefits from a well-established family hub network and a really committed health visiting service, which are really important strengths and assets and a real platform for prevention. Stakeholders perceived opportunities for a bit further alignment between maternity health visiting and early help, so parent-infant relationship support can be more consistent across Derby City wards, particularly in areas of high deprivation. For the primary school aged children, many Derby City primary schools are engaged with emotional well-being. Some schools have that good whole school approach practice in place. We identified as a Year 6 transition package in local practice that stakeholders considered a really useful exemplar for supporting pupils before they move on to secondary school to help build resilience. However, we saw that there was variation across schools and capacity and the consistency of personal, social and health education and that whole school approach across the schools in the city. Partners saw, therefore, that there was scope to consider more structural support for schools to implement the whole school approach with a bit of quality assurance around that, linking in with the mental health support services in schools. For secondary school aged children, we found pretty much that the city mirrors national adolescent trends. Stakeholders reported rising emotional distress and anxiety amongst adolescents post-pandemic. Schools noted higher demand, as we mentioned, particularly around exam stress and social pressures. Partners in the system described an increasing number of young people who needed increasing low-intensity support to prevent escalation. And that raised the importance of having clearer pathways from school-based support into targeted services when needed. Just finally, talking about our young adults, age group 18 to 25, I think we found some data was a bit less complete there. Partners perceived that as a gap. The needs assessment in this aspect highlighted that some young adults, particularly students and those facing housing or employment instability, can fall between service models. Therefore, there was an identified need by stakeholders for better mapping of higher education and further education counselling provision, clear routes for support for young people in that age band. Across the city, partners identified inequalities as a persistent theme. Children intersecting vulnerabilities, for example, those with SEND, care experienced children or families living with poverty and housing instability, are more likely to face barriers to support. So the assessment therefore endorses a proportionate universalism approach with a universal offer plus targeted intensity where it's needed. Again, I think it's important there, just having said all that, to really emphasise the positives. I think through this needs assessment work and engagement with partners, we've really demonstrated that Derby City has committed partners around children's emotional well-being and mental health in its most broadest sense, with active family hubs, engaged schools, and an involved in voluntary sector. The Youth Mayor, as I mentioned, initiative was a strong example of meaningful youth engagement, which we can certainly build on going forward. Some of the challenges we experienced was the cross-working with health partners around data intelligence and around service uses. So one practical theme that came through in the stakeholder discussion was the need for better integrated intelligence between local authority and the NHS around NHS commissioned services. Local authorities have strong education and population data, but the access to consistent NHS mental health operational data, including particularly CAMS referrals, waiting times and outcomes, was variable. So that's definitely a service development opportunity going forward with improved data sharing and analytical capacity, and that's particularly relevant regarding the clustering of the ICBs and how shared intelligence will work better going forward. So looking at the proposed action plan, it's trying to be pragmatic and invitational rather than directive, intentionally non-prescriptive, and asking partners to consider a sequence set of enabling actions to co-design delivery locally. I think one of the most important ones going forward is to establish some increased governance around children and young people's mental health by convening a 0 to 25 system-wide children's and young people's mental health and emotional well-being oversight and delivery group. At the moment, there's a children's delivery board with ICB with system partners. There's a mental health delivery board that is developing now into a more strategic, I think, both groups. Within, there's obviously local authority service mental health for children and young people, but I think that there's a case for having something that's a bit more distinct and separate from that, because it kind of gets lost in between. Also commission a whole school approach and that quality assurance function to make sure that it's been delivered most effectively. Initiating CAMS and wider children and young people's mental health data integration into a shared population health management dashboard came up as an action plan in the first initial action plans in the first year. Undertaking trauma training audit and planning initial rollout of targeted training and reflective supervision, and developing options appraisal for parent and relationships provision in Derby. Sort of medium-term, longer actions over the next 1 to 3 years. We've asked partners to consider upscaling whole school approach support across primary and secondary settings, and expanding the mental health support team coverage and getting more integration around that. And piloting youth-friendly access models for 18 to 25-year-olds, for example, evening clinics, campus-based offers. A lot of things that are being done, but there's this scope for improving is that. Just a final thing about the governance of the group, and mention again about the changes in the system regarding for the clustering of the ICB. Many of these issues cross organisational boundaries. I think the recommendation that a joint chaired oversight and delivery group offers the, as I said, the most practical forum for partners to agree shared priorities, and that's really what I'm came to ask scrutiny in the Health and Wellbeing Board to endorse. Aligning that board with a co-chaired Notch 25 oversight group creates a physical route to shift the assessment into sustained action. The governance group would focus on enabling change, monitoring delivery through agreed dashboard indicators and ensuring young people's voices remain central. So in closing, we're inviting Health and Wellbeing Board members to note the findings and the collaborative place-based approach of the revised recommendations, support the principle of establishing a not to 25 children and young people over mental health and emotional wellbeing oversight and delivery group as a mechanism for shared stewardship, encourage partners to prioritise the short-term enabling actions, particularly around data integration and the expansion of the whole school approach, and to consider how prevention budgets can be rebalanced to support early help, and then request suitably timed updates going forward in that. So just a final remark about this assessment and this assessment provided a grounded shared starting point for Derby City and across the county colleagues, draws in local evidence, which I think was a great strength of the work, stakeholder insights and lived experience of young people, and highlights the strengths we can build on the practical opportunities partners may wish to consider, all with the aim of improving outcomes for children and young people in our city. Thank you, and happy to take any questions.
Thank you, Alan. I mean, that's quite a comprehensive report, isn't it? And as you say, no doubt it just seemed to grow and grow and grow as the more you look into it. There's an awful lot in that, and there are actually some fairly substantial recommendations we need to consider this time from Alan. So before we move on to those we don't have to, no, I mean, either on those or any other general comments or questions that people want to make. Andy.
Yeah, thanks, Chair, and thanks, Alan, for presenting that so well. I mean, it is very ambitious, and I think the work that's taken place is really impressive. I think the fact that we've got something that's all ages is really helpful for the city. The engagement of young people, the youth mayor and so on, I think adds real strength to it. I think the recommendations are really interesting, and I think if they are implemented as outlined, could be really helpful and really impactful. But I'm also mindful it's quite a busy space, and there are conversations taking place quite appropriately, as you outline, within different parts of the system. So a CYP delivery group within the ICB, which I chair, for example. Mental health is a really key aspect of the inclusion strategy and the local area inclusion plan, which involves schools and broader inclusion services. And we're often talking about the same children at different points in their career, really, or at different ages and so on.
Your mic up.
So it's just something for me about how do we ensure that the group that is going to provide that stewardship, I suppose, is as effective as possible, so it doesn't just become another layer or another meeting, but actually does try to pull those threads together, because I think there's a real opportunity here to really try and tie up the discourse and just to ensure that we're making maximum impact and that we're really thinking about those things that are coming out from the centre, for example, and how we try and, impact across the city, and also potentially enables us to be even LGR-proof as we go forward over the next 12 to 18 months. And then just another practical point, and I think there's already been a bit of a conversation with the Local Area Inclusion Partnership. This will be a really important report to bring to that group, because that's where you've got the strategic leaders from schools, and mental health is such an important aspect of inclusion, and probably something that comes to the CYP delivery board, or I could take it there because I chair that, so we can have a conversation about that. But I think really supportive, and the recommendations I would support is just about how we do it, which I haven't got to answer now. We can work that through, but I think that would be my kind of just reflection. But thank you, Chair.
Thank you, Andy. Did you want to come back on that, or should I take Kim first, Alan? Do you want to come back on that, or now, or should I let Kim comment first? Yeah, Kim Harper, please.
Thank you, Chair. Again, really welcome the report, and I am aware that there's been lots of engagement and involvement, particularly around communities and voluntary and community sector to get to this point. I think where I am concerned, there isn't much of a mention in terms of that delivery and that ongoing involvement. And one of the issues we've had previously, and I think I've mentioned it in this room before, is GDPR and data sharing. if we're genuinely going to do this in a partnership approach, I think it's really important that we sort of reach out to communities and ensure that they're able to be involved in these programmes and that co-delivery. I think often we get it seems to be one way or the other. It's either co-design and delivery we get right, or it's at the other end where it's sort of... And actually, it's how we manage that together as a partnership. I think that would be really important in terms of success. But I really welcome the report, Alan, and I think it's the way forward. And take on Andy's point as well in terms of we do need to make sure this is connected in, because it's something that we do keep coming up against. For me, it's quite ambitious. Let's genuinely make it happen.
Thank you. Yeah, so there are long-standing data sharing issues, aren't there, within different parts of the NHS, and the ICB has been working on this for some time. The Derby and Derbyshire one was working on this. I think Nottingham and Nottinghamshire were always ahead of the game anyway. So I just, other people will know better than where we are on this than I do. But Claire, you wanted to come in.
Yeah, thank you, Chair. Really good report. What I would say, similar to my colleague here, actually, I think particularly, I know I'm a relative newbie now, but this probably needs mapping to some existing governance for me to fully support the recommendations. I think they're the right thing to do, but what we can certainly ill afford is multiple spaces where we're having the same conversation. So I just wonder if there's a bit of scoping to be done on that, but absolutely, I think they're the right things to do. On the data sharing, because I note some of those are down for ICB, it's right actually across the three ICBs. We're further ahead in the other two in terms of data sharing than we are in Derby and Derbyshire, and we have been doing some work on that. How far that reaches, though, I don't know and couldn't answer that today, so happy to take that away. So I think I'd want to have a conversation with our executive director that's got the lead for children's as well, and around mental health, just to make sure that we're not duplicating. But absolutely, I think all the things in here do need to be done. It's just where and what's the right oversight structure, I think.
Thank you. So I will definitely come back to your point, Claire, and Alan might want to as well, when I kind of summing up and looking at the recommendations. Councillor Kerr.
I love the sort of feeling that this gives me of a sort of a safety blanket wrapped around people as they're growing up. And I think that as a sort of a concept for, you know, mental health support through, you know, earliest years through to young adulthood is really nice. But it also leaves me that feeling that we're supposed to have these sort of services already, which I think that colleagues have sort of reflected on in terms of how do we do this. The other thing that this doesn't, I don't think you've highlighted, and I didn't read it here, is the role for self-help, though obviously that comes out of Kim's views of things. And we've got more emphasis on mental health first aiders and peer support, which also ought to be part of this thinking. And that, because otherwise I feel we haven't got the capacity within the public sector to be doing more. We can only rearrange what we are doing unless we're bringing in those other resources from peers, from one's own community. And I think that we need to embed that thinking within this as well. So yes, Chair, it's wonderful. Let's get the recommendations right.
Thank you. Did you want to come back, Alan?
Yeah, thank you for everyone's comments. You know, going forward, we are taking it to the inclusion board, and we've got another children's delivery. I'm going to go along to that just to raise that, and with your help again to get some conversations going there. I think it's going to be something that will take a while to recognise to get the governance sorted out. I mean, as I said, I've just made some based on the feedback, some recommendations that have been shared, invitational that the system, the complicated system might want to think about. I think what I've learned from my own reflections of the work is that I think children's, in its broadest sense, mental and emotional well-being for this age group does need its own focus rather than being a children's young people's delivery group and a more adult focused mental health delivery group with a subgroup for children underneath it. I think it does, and given the pressures that I talked about post-COVID, social, what we're hearing from the children and youth mayor survey, the impact of social media, I think it really deserves its own focus for the city going forward, and could be something that's really branded well through place partnerships and neighbourhood working as well. So I'm excited. I think there's really good opportunities to give this a real focus.
Thank you. Any other comments or questions? So my sense of this, Alan, is that in terms of your recommendations, that people are more than happy to support 2.1, that they've obviously listened and noted and actually appreciated the report and the ambition and the scope of the report. I think that in terms of 2.2, I think you've made the argument. It might be about creating a bespoke board. I think my sense of it is that, forgive me if this is wrong, but is that if you do want to press that particular line, I think you need to give a very compelling argument and to actually perhaps support it with some more data, evidence, if you like, of the scope of the problem, and also some more governance thought about how having that specific board would help on the delivery side. I think from what Andy Smith was saying and Claire from the ICB. So my sense is that at the moment, as a Health and Wellbeing Board, we probably can't support, we're not going to support recommendation 2.2 right now, because the key partners who would have to be involved want more thinking about it, but there isn't a rejection of it either. So I think, is that fair enough to say, Andy? Yeah.
I think maybe, Chair, in principle, subject to a little bit more thinking.
I think that's what I said, Andy. But thank you for that nuance. So I think, well, my sense of it is that we're not quite ready to fully back that as a proposal at the moment. So, but it is supported in principle, but it needs more thought. But leaving it like that means there's an obligation for people to give it more thought. And then on 2.3, we have, I'm not sure that we've fully discussed this, endorse the agreed short-term priorities for the system partners set out in the action plan. I would take views on whether, as a board, we think we can endorse that recommendation now. I know that people have very much appreciated everything you're saying and the general direction of travel, but those are specific asks with specific tasks and a sense of timing to them as being short-term, and I'm sure they're all valid, but I need to know, I think we should have voices or some response on whether people are prepared and happy to support and act on 2.3. Councillor Kerr?
I think you're right, Chair. I would rephrase 2.2 to say to support the concept of a 0 to 25 children and young peoples. And then number 2.3 would be to bring back further detail of how this would be able to work in a future meeting.
That's a proposal from Councillor Kerr. I'm sorry, I'm going to turn to Andy and Claire to take your views on that, please, as you're the would-be key partners here.
I mean, I'm happy to support that wording. Yeah, feels pragmatic. Still taking it forward, Alan, but yeah.
So, thank you, Alan. So I think again, in principle, people support 2.3, but they probably want a bit more detail and coming back again, or discussions outside the meeting with partners. So, so thank you very much for a kind of pioneering report with some substantial asks. And basically, you've got the support in principle. We just need to work out some more of the detail. Thanks, Alan.
Thank you very much, Chair.
Okay, then. So moving on to another area of interest, perhaps less so of interest to the public out at large, but of interest and concern to us as a Health and Wellbeing Board and the ICB, no doubt, is the Neighbourhood Health and role of the Health and Wellbeing Board. And Robin, you're going to lead a discussion on this. And I would stress that I think this is going to be a bit of a discussion where we can reflect on some of our, as a as a local authority and health and wellbeing board to make self, some of our knowledge of our non-knowledge, it's perfectly acceptable to talk in that way. Because I think that's what we're going to have to talk about around this. But Robin can explain. Thank you.
I'll certainly give it a go. Thank you. So yeah, the paper's there, and it's just giving an update on our understanding, and I think that's part of the challenge, is that we don't have clarity at the moment, but just to ensure that the board's aware of what the conversations are and what the ask might be, and to seek your views really on this. So just over a year ago, the neighbourhood health guidelines were published, and they were discussing the need to transform the health and the care system. And I think that's an important point to make as well. We're talking about neighbourhood health plans, but we are very much talking about health, social care and public health within those health plans. And just an urgent need to move care closer to home, to improve people's access and experience, and to ensure that our services are sustainable. And there were 6 parts of that development, so around population health management, around general practice, looking at community health services, looking at neighbourhood multidisciplinary teams, integrating intermediate care and a home-first approach, and urgent care in neighbourhood services. And then in the summer last year, we had the 10-year health plan. And obviously that had those 3 themes in it around hospital to community, analogue to digital, and treatment to prevention. And as part of that plan, there was a statement that there would be neighbourhood health plans that would be drawn up by local government, the NHS and its partners at single or upper tier authority level under the leadership of the Health and Wellbeing Board, incorporating, as mentioned, public health, social care and the Better Care Fund. And the integrated care boards would bring together those local neighbourhood plans into a population health improvement plan for their area. Now, I think probably we're a little bit out of sync with those, aren't we, in the guidance that's been produced, but that's the overarching aim, that will be done. And we were expecting national guidance to come out in the autumn around what these plans would entail, and an anticipation that they would be developed and approved by the beginning of April. So there's been a little bit of anxiety that guidance may come out at short notice, and a concern as to how we would respond to that as a board, because we wouldn't want to not be involved in the production of those plans, and we want to do that properly, but also mindful that there might be some really short timescales involved. But as today, I certainly haven't seen any of those plans. We haven't seen them, have we? No. So we're still waiting for that guidance, and I understand that there's still a bit of a national conversation around the role of the Health and Wellbeing Board. And right at the end of the paper, and I will come to that, we've just got in what the current statutory duties of the Health and Wellbeing Board are. And there's a real implication that there may be changes to that. So the national messaging, so I'm just at 4.6 here. Anticipation that those changes might be around not only approving that neighbourhood health plan, but being accountable for its delivery, convening partners and providing that system leadership. And part of that is particularly around reviewing the membership of the board and ensuring we've got the right people here on the board in order to do that. Evidencing achievement and being accountable for improvement of population health outcomes. Focus on the preventative action and bringing people's voices to the forefront of neighbourhood health. Aligning and pooling sharing of resources, and also providing that democratic accountability. And I think some of those things are in place for us as a board, but it's very much suggesting that we'd have much more of a role in ensuring actions are taking place, a little bit more around performance management potentially within that. So work on the development of neighbourhood health itself is very active and is progressing. But there are risks that also may go ahead of our ability to come together and to develop these plans, and for us as a board to really co-produce that. So there was a webinar held, which Alison attended last month, and this was from the LGA, Health Integration Partners, Empower and PPL, so a group of support who are working together on this. And it was particularly looking at how we develop shared vision and priorities, shared accountability, and that importance of being data-led. But there was very limited information in that around the role of health and wellbeing boards, which I think reflects that national conversation that still has some uncertainty around it. So there was some concern that was raised on that webinar, which was around the potential involvement of local authorities, and I would also say the voluntary sector as well has been raised in some of our other meetings, and our health and wellbeing boards in shaping this. And that risk that it's not currently our role, but this direction of travel could bring the board to be much more focused on healthcare delivery and moving our focus away from prevention and wider determinants. And that issue that actually there is no resource underneath this board. We all work here as partners, and it is very much around our day job to deliver everything that we agree in this board. So it's currently anticipated that these neighbourhood plans will be an addendum to our health and wellbeing strategy. And as you're aware, we've been developing that, and we're just in the final stages of updating a document that we should be bringing back next time for consideration by the board. And to also mention that we're about to start working with the Institute of Health Equity. If anyone has heard of the Marmot Places programme, we're about to just start and begin that work with the Institute of Health Equity, and that will also contribute towards the development of future strategy as well. Derbyshire County and Nottingham City Health and Wellbeing Boards have been involved in a local government association support offer around developing neighbourhood health, and there will definitely be some learning from that we can share. And then just in 4.11, there's the current statutory responsibilities of us as the Health and Wellbeing Board. So it's promoting integrated working, it's preparing and publishing those documents, so the JSNA, the Health and Wellbeing Strategy and the Pharmaceutical Needs Assessment, to express an opinion on applications for pharmacies, and to receive, consider and approve plans associated with the Better Care Fund. So in order to take on any of these responsibilities, there would need to be a change in that legislation for us to pick that up. So it's really a conversation today around people's thoughts on that and how they would like to be involved in the development of this work.
Thank you, Robin. I mean, just to comment on me before I bring others in, and I know some people have, in the room, have tried to work on this from their own area perspective. And I suppose for me, I think I would personally, especially as we're anticipating, although it's still in anticipation, we're anticipating the demise of the integrated care partnerships. So I think personally I would welcome a strengthening of the Health and Wellbeing Board along the lines suggested, but I think very much, as you pointed out, we would need, there would need to be some restructuring of the board, there would need to be more resources. I mean, at the moment, the very specific statutory duties we have, we do obviously comply with, led by Alison, and then we have general integrated working discussions. It's a very discursive board, isn't it? It seems to me that what they're suggesting on page 2, and I'm not against this, but we would need to change in road. What we've got now is like a partnership group. The kind of notion of a board is much more of a directive board. And the problem with accountability, I mean, at the moment, perhaps sometimes they regret this, but at the moment, for example, I am accountable for certain areas of this council, and there are people, senior people in this organisation who are responsible for me, for making sure that my accountability to the people in Derby can be fulfilled, and then therefore there's an element of, I'd hasten to use the word, I don't like to use the word authority, but there's a relationship of expectation there for certain, for pre-established parameters which we know about. At the moment, the Health and Wellbeing Board has no authority as such, other than being full of people who ought to be listened to and engaged with, and ought to listen to and engage with other, and actually probably largely do, for the sake of the people in Derby. So it seems to me we're looking at a completely different beast. And then, but in the meantime as well, we need to have some sense of when, where, or how we're going to, this neighbourhood plan is going to be produced, or whether we just approve it, or whether it comes from the ICB and we're just an approval body, or whether we input. So I think there are, just as the chair, I'm just commenting, I think there are some really serious questions here. There's an opportunity for members of the board to, in a sense, have more of a more bite, but that would come with more responsibility, and with that responsibility we need more resources, and we need some, you know, even if it's just basically institutional form of some form of sensible authority, which I don't think we have at the moment. So thank you, Claire.
Yes, thank you, Chair. It's an interesting space, this one, at the moment, and quite fast moving. So couple of things that are probably worth mentioning. So I think it might be fairly imminent now, where they've been saying that since December. And I say that because I've received, and you should have as the Chair, I assume, a set of invites over the last week to various webinars in the next 10 days. So there's ones for chairs and vice chairs of health and wellbeing boards. I received that because I'm a vice chair of another health and wellbeing board. One's for officers, and then one's for wider partners, I think, from memory. So that suggests that there might be something coming out. That's just a personal view, of course. So I think we will hear a little bit more about it. My sense is they're positioning health and wellbeing boards. The reason that they're talking about who needs to be on them is because I don't think it'll get an authority. It'll be an authority of the partnership by definition of the people around the table. That's the sense that I get. Whether they'll change that or not, I don't know. But in all of the meetings I've been in, and the sort of national calls and webinars, it's very much that the leadership needs to own the direction of the health and wellbeing, or the neighbourhood plan built on the health and wellbeing strategies that we already have in existence. So there's two other points that are relevant in the paper about ICB duties. So we've had to produce a 5-year population health strategy in early February. So bearing in mind we only kind of came into being in the November. And we've also had to produce a population health improvement plan / commissioning plan. So I'd be very happy to bring both of those to your next meeting. They're going to our public board at the end of this month, and there'll be public versions of that available after that. But very happy to bring that as a specific paper, just so that you can see what's in that. And there's quite a bit around neighbourhoods in that from an NHS lens, as we understand it at the moment, and as we're instructed to commission, if that makes sense. But for me, the really important thing is neighbourhoods means many things to different people. I think there's a real opportunity around public sector and strategic intent around neighbourhoods and what we want to do. And I don't want it to be seen as just an NHS thing, because it really isn't. It needs to be much broader than that, and I think we probably all recognise that. And I think that's the bit of work that potentially the board could commission even today, a sort of subgroup to start to look at that. There's lots of work going on, isn't there, in Derby City at the minute around neighbourhoods and place. So, but actually in the lens of what we think is going to come, given it's pretty close, that could be something we do. I'm on 5 health and wellbeing boards now, as you know, and I came from the Lincolnshire side of the patch. And we've been doing that quite actively in preparation for this announcement, because we thought it was going to come in December. So that's already making some progress. And again, I'm sure they would be happy to share. I know through the Directors of Public Health there's been conversations. So I just think we ought to take it as an opportunity to think about who do we need on this board if that is going to come our way. But even if it doesn't, isn't it the right thing that as public sector we should be starting to think more broadly about how we could look at joining up some of our neighbourhood working?
Thank you. So just a quick side. I'm aware that there's a microphone on. Sorry, is it? I can't do the name. It's behind. There's a. Yes, sorry, I can't think. Could we turn that mic up? Thank you. Sorry. Thanks. I've just seen that. Thanks. That will be slightly dulling the sound of people's voices. Thank you, Claire. I'm not sure I quite picked up on what you exactly proposing there, and I don't necessarily expect you to repeat it, but there was a point where you were saying, I think that the problem is, I'll let other people come in, but I think we're not, there's been a desire to start working on something, but we don't know what it is. I mean, I'll let other people come in on this, because I've already had my piece. I have genuine and remaining concerns, and they wouldn't be as somebody who is accountable to the public directly, I think where you have accountability with no given way of expressing, of making those responsible accountable to you, I mean, you can own it, but actually it's the worst of all worlds, and it's one I think we should avoid. We can't be accountable as a body for people who we don't have lines of some kind of, perhaps authority is the wrong word. So we can own it if we like, but if we can't actually hold people to account for their responsibilities, then it's a sort of a weak, I suppose, position to be in. But it's also, for a politician, it's not a desirable position to be in at all. All my fellow councillors are nodding. For all that, if this can be beefed up to have the mechanisms within it, then I would be very in favour of it, and I'm not, we're not writing it off or anything. It's just, it just could be vacuous, well-intentioned stuff, actually, to be honest, if we have no way of, we're not going to own things for which we have no mechanism of holding people to account. I mean, we do try and hold people to account now, incidentally, and we do own problems, and, we do, when people haven't been engaging with the Health and Wellbeing Board, we've been talking to them, and sorry, there was a point you made about what we can do now. I don't know if you need to report it, Claire, because perhaps everybody else got it, but I don't think I could totally hear you. I don't have the best hearing, because I think there was a mic on over there.
No problem, Chair. I think all I was suggesting was that whilst there is a vacuum at the moment, there is perhaps an opportunity for a number of people to get together underneath the Health and Wellbeing Board with support from members to kind of discuss this a little bit further, and just I know there's lots of work going on already in terms of place and neighbourhoods and partnerships, so so it was just an offer really, and just an observation from what I've seen elsewhere as I go across the other health and wellbeing boards, but that's not to say that you need to do it. It was just a thought.
No, I welcome that suggestion. Thank you, Claire. I literally couldn't hear you, but I can hear you properly now. We've had that other mic turn. It makes quite a difference when there are several mics on. Thank you. Andy Smith.
Yeah, thanks, Chair. Just 2 or 3 points to make. I think that pragmatically, until and if there are any changes to primary legislation, the focus of the Health and Wellbeing Board is pretty much the focus of the Health and Wellbeing Board. So whilst there might be an ambition in a 10-year plan for the Health and Wellbeing Board to have a larger reach or remit with a broader array of responsibilities, we're not in that space yet. In the same way, we're not in the space yet where ICBs are going to be scrapped. It's something that's in the 10-year plan. It will need primary legislation, and we are where we are at the moment. So I think it's important for us to understand what the future might look like, but we are currently in a place where we need to be clear with what our statutory duties are. I think in terms of the recommendation from Claire around what do we mean by neighbourhood working, locality working, place within Derby City, I think that it might be helpful for, because we've had previous presentations here from ICB colleagues, albeit before the shift into the cluster, on some of the work that's been taking place in the city and across city and county in relation to neighbourhood working, and trying to join things up in terms of the different pieces of reform that we're trying to piece together to make sense of communities. And there is quite a lot of work going on in that space, and I do wonder if we need to think about how we cite the Health Wellbeing Board on that, and also how that informs some of the work on the revised Health Wellbeing Board strategy that I know we're currently leading on. And things are moving at a pace because that's just the world that we live in at the moment. But you know, there is conversations taking place across the provider health organisations, both local authorities, including DASs, DPHs, DCSs, and the voluntary sector on what we mean by neighbourhood working, locality working within Derbyshire. So we're not starting from scratch in that space. So I do wonder if there's, you know, a future opportunity to bring that here in terms of this is where the work is at, and these are the issues the Health Wellbeing Board to reflect on. And then I suppose the other final point to make is that I think you've said it, Chair, and I think it's in the report. You know, we are in a bit of a vacuum at the moment, and I think that until and if we get guidance that comes out, I don't think as a Health Wellbeing Board we're going to be in a position to develop or sign off any plan. I think we just have to recognise that that's the position that we're in, and until the guidance comes out, we can't actually do anything. I don't think it's advisable, Chair, for the Health Wellbeing Board to be second-guessing what the guidance says or making things up or filling the gaps in. I think we have to wait for that guidance to come out. And I appreciate that, you know, the government has got a hefty agenda at the moment in terms of public sector reform, including the NHS and local government and the public sector in the broader sense. But I think we just have to hold our nerve and just see what comes out and then respond appropriately and in line with the guidance. So I just think we have to note the position, but I wouldn't be suggesting that we do anything other than just wait for the guidance at this point, Chair.
Thank you very much for that. Thank you, Andy. Councillor Kerr, and then I'll bring you then Kim.
I was also, before Claire spoke, I was thinking, what do we mean by neighbourhoods? If you're talking about an organisation that is across Derbyshire and Nottinghamshire, neighbourhoods might be bigger than the two neighbourhoods that I think I'm looking after within my ward. So I think some discussion about what neighbourhoods mean, but I think it needs to, as well as the other things that Andy's mentioned, I think it needs to also be put into the context of local government reorganisation and the presumption that we're not going to have a Derby City Council within 2 years, and therefore we will be having to look at different community boundaries than we are at the moment and what that will mean. And I think he's also pointed out that we can't do this all now, and it's not just Derbyshire that is having this reorganisation happening. That's happening across the country. So I would have thought that the advice that's coming out from London is going to be cognizant that there are 20 areas where local government boundaries are going to be shifting, and therefore that is a significant proportion of the country, and they shouldn't be trying to impose yet another change on top of that. So for people and for colleagues who are further from local government to be aware of what's going on, I think it's vital so that we can be aware of the sorts of things that will need to be happening without having to do them immediately.
Thank you, Councillor Kerr. Kim Harper.
Thank you, Chair. I think it's partly to build on Andy's point, but also to stress from our perspective, the refreshed health and wellbeing strategy is something voluntary community sector, the VCSE Alliance, Derby Health and Equalities Partnership over the last couple of years really been involved in, so wider community involvement is essential in terms of that form of planning for me. So it would be really important that the voluntary and community sector are part of these plans as well, because we don't want to lose that position. From an ICB perspective, I myself have sat on the partnership board, and I think it's really important that we retain those relationships and build on them, because fundamentally voluntary community sector, particularly at a neighbourhood, locality level, are absolutely essential in terms of making some of these changes and the support moving forward into the future.
Thank you, Kim. I mean, I'm sure that is the intention. I mean, and yeah, I'm sure that is the intention. There will need potentially need to be some changes or some reflection on the statutory makeup of the statutory members in the Health and Wellbeing Board anyway, won't there, Alison? Because, I mean, we're really welcome Claire here today and your experience of 5 Health and Wellbeing Boards. I mean, it's unbelievable really what you're taking on. And we do appreciate the ICB has had a major change imposed upon it and all the stress and the demands that implies. But we, the Health Watch is going to be discontinued as well, and they're the 3 statutory partners. So, so that will need looking at, Kim. But I'm sure we will not ignore you or the voluntary sector either. So that will all come into play, I'm sure. So I guess for now we'll leave that discussion. Claire, if you've got useful, as you suggested before when I met with you, if you've got useful work and documentation you could send to us, please do, and we can think about that here in Derby, or Alison and I can look at it, and perhaps Robin, and we'll work on that. But for the moment, I think there seems to be a general view that we can't do too much until we get the guidance, but it's just to make people aware of the guidance. So we could, I'm sure it will be positive in the end, just we're in a bit of a state of non-knowledge at the moment. Right, thank you very much for that for everybody. Now quickly moving on then, in the last few minutes, quick update from Robin on the Health Protection Board. Do you want to speak to that, Robin?
Apologies. Just to quickly pull out some of the key points. So the last meeting was in January. We're actually meeting again next week. And there's just a summary there of the areas that we discussed, a particular focus on immunisation and some challenges around the school-aged immunisation programme, particularly with the flu programme in the autumn that we are working with NHS England and the ICB to try to improve. To note that there is ongoing work to transfer the responsibilities for commissioning immunisation and screening to the ICBs from April of next year. And just to say that I know we've discussed the issue around infection prevention and control in community settings previously. We don't have a resolution on that at the moment, but we do have a meeting planned for Friday as well to discuss that further. So hopefully we'll be able to progress that. And we have established now, under the Vulnerable Populations Group, we have a group specifically looking at care settings that are just scoping out what the areas of work are going to be there.
Right, thank you, Robin. I think, Alison, any comments on the forward plan?
No, it's really just there to know, but just for board members to know, I think there's a few things that have come up today that will add to the forward plan, and obviously there's the oral health strategy that we weren't able to take today that will add onto that. Thank you.
Okay, we never lack items to bring, do we? There is certainly a desire to bring things to the Health and Wellbeing Board, which is good. And thank you for everybody who's contributed today. So that's the end of this March meeting of the Health and Wellbeing Board. Thank you for attending and look forward to seeing you next time. Thank you.